Okay, so today we're going to start with just some general background on monkeypox and the current outbreak. Talk a little bit about the clinical presentation and epidemiology, and then give some pointers on infection control, outline how we're doing case and contact management, then discuss a little bit about the testing processes, and then give you a little more information about our new and exciting initiative offering vaccine to high-risk populations. Next slide. Okay, so starting out with a little background, monkeypox is a member of the orthopox virus family. Other viruses in this group includes variola virus, which causes smallpox, and vaccinia virus, which has been used in the smallpox vaccine traditionally. And just of note, there is some confusion, despite the name. Monkeypox is not actually related to chickenpox, although they can present similarly in certain stages. And with monkeypox, there are two major clades, or sort of subtypes, so to speak. One is the Central African clade, which is considered a more severe form, which can carry with it about up to a 10% or more case fatality rate. And then we have the West African clade, which has been more mild and has, prior to this outbreak, been about a 1% case fatality rate. However, it's really important to note that this is really in cases that have happened in rural Africa with very limited access to medical services and in younger populations. So this current outbreak that we're seeing globally is caused by the more mild West African clade, and we anticipate that just given the improved healthcare services and where these cases are occurring, there should be a much lower case fatality rate. All right, and then monkeypox as a virus was first discovered in 1958 among research monkeys that developed a pox-like disease in Denmark. So that is where the name came from. However, the actual natural reservoir of the virus is unknown. However, we do believe that African rodents and non-human primates may harbor the virus and infect people as well. The first human case was reported in 1970 from a child in the Democratic Republic of Congo. And historically, prior to this, human cases have really been limited to several African and West African countries, but not seen much outside of the African continent. Next slide. And so previous cases outside of the continent, I think the most notable is what occurred in the US in 2003 when there was an outbreak that was related to imported African rodents that were then housed near some other mammals, specifically prairie dogs, that were then potentially, infected from these exposures. And then the prairie dogs were then disseminated to pet stores in parts of the country that then, when they were taken home, there were exposures and led to an outbreak with 47 total human cases that were identified from contact with these infected prairie dogs. And this was really the first time that we had seen human monkeypox outside of Africa, and especially with sustained human-to-human transmission. And then in 2021, we did have 2 imported cases. Both were associated with both occurred in travelers that had returned from Nigeria. One was in Texas and one was in Maryland. One case was quite mild and was managed at home very easily. The other did require hospitalization. And then just, there have been some sporadic cases in other countries, all associated with returned travelers. We saw in the last 5 years, there have been cases in Israel, the UK, and Singapore. Next slide. And just looking at where we are as of now, this is a very rapidly evolving situation, but globally, we have now had cases reported essentially in every continent outside of Antarctica, or every country and continent, every continent outside of Antarctica, sorry, tired, with a total confirmed cases so far, and these are just the confirmed cases of 3,308, although we suspect that this number is probably much higher as more mild cases may not present for care and identification. And 42 countries have now reported cases. Next slide. And specifically at the US, as of, I believe this is as of today, we have a total of 173 confirmed cases with a median age reported of 37 years with a range from 20 years of age to 76 years of age. We have a handful of states responsible for a majority of the cases with 10 or more cases each, and that includes California, Florida, Illinois, New York, and Massachusetts. Most notably, California is now leading the pack with over 40 cases because they've had a specific outbreak associated with a particular bathhouse that they're investigating. Next slide. And this is just an illustration of our epidemiology curve so far since the mid-May when we identified our first case, and we have a total of 30 confirmed cases. Next slide. And so just talking about transmission, person-to-person transmission is the most likely route that we're seeing through direct contact with an infected person's, particularly contact with lesions or body fluids, and also potential for indirect transmission through contact with fomites contaminated by an infected person's lesions or bodily fluids. Notably, there was a report that we'll mention a little bit later of in the UK, a healthcare worker. This was a couple years ago that had been changing bedding and had been agitating the bedding as they were changing it without respiratory protection, and they believe that did lead to transmission. But that seems to be a rare form of transmission, but certainly possible. And then also, we believe it can be spread through exposure to respiratory secretions, more through what we would traditionally call the droplet route, which would really be through prolonged face-to-face encounters. Or, of course, always a risk when performing aerosol generating procedures. Next slide. And so looking at the clinical presentation, so just to kind of take a step back, and we have sort of the traditional way that we've really thought about the clinical presentation prior to this outbreak, and then I'll talk about how this is a little different. So really traditionally, we think about the evolution as, first the development of flu-like symptoms, which are, what we call the prodromal illness, which the patient would probably have for a few days before they start to develop a rash. The rash had generally started more around the face or oral mucosa, and then spread out centripetally, we say, mainly to the extremities, including the palms and soles of the feet, usually sparing central areas in the trunk. So that's sort of traditionally kind of how we've seen it. And the rash develops first, generally you see macules, which are the colored flat lesions, which are very nonspecific, of course. Then they can evolve to papules, which are the raised lesions. Then vesicles, which are, of course, are more blister type lesions, and then pustules, and then they would crust or scab over, and then eventually fall off. So the current cases, we are seeing, mostly typical rashes, but there are some atypical features to talk about. They're often, instead of where they traditionally had started kind of more up top, many have been starting in the genital and initially presenting in genital or perianal areas and orally. And depending on when the patient presents, the progression of rash may not appear characteristic, especially, during early stages of progression. So it can make, it's important to have your sort of clinical spidey sense up, when evaluating rashes. Rashes are, in this outbreak, sometimes not disseminating to other parts of the body like they classically would. And lesions, as opposed to traditionally, where lesions tend to be in the same phase, in the same phase of development throughout the body, we are seeing that lesions with this outbreak may be presenting in different stages of development, which is something that we're kind of learning about more and more. And we believe, of course, that the location of the rash and lesions in this outbreak are reflective of the initial points of contact or points of exposure. And we are certainly seeing that proctitis may be an initial complaint or component without even having a easily visualizable rash. So, again, diagnostically, certainly should, have that in the back of your mind when you're evaluating for proctitis symptoms. Prodromal symptoms, they may be mild or not present at all. Sometimes they may not be detected or appear before the rash. They might come after the rash develops. But typically we've been seeing things such as fever, headaches, myalgia, lymphadenopathy, night sweats, and chills. Next slide. And in terms of infectiousness, so we would consider the patient infectious from the onset of symptoms. So whether that is the kind of prodromal flu-like symptoms or with the onset of rash, whichever comes first. And isolation precautions should be continued until all the lesions have resolved, the scabs have fallen off, and there is a new fresh layer of skin forming. So that whole evolution of the rash until isolation can be ended typically takes about 2 to 4 weeks. So the isolation can be pretty prolonged in some cases. So far, we've been seeing generally pretty mild self-limiting disease course without the need for any specific therapies, but we will talk about therapy a little bit later. Some complications that could happen that have been reported more in previous outbreaks in Africa can include pneumonitis, encephalitis, sight-threatening keratitis, and particularly secondary bacterial infections have been a cause of mortality in previous outbreaks. We, of course, also have a risk of significant scarring from the lesions, and which can, cause complications, particularly, if there's strictures or scarring in the anogenital tissue. And the prognosis, of course, depends on multiple factors. Generally, people without, underlying significant medical issues, do quite well that are underlying healthy. However, concurrent illnesses, comorbidities, immune compromise, and other things may impact the course of the disease and make it somewhat more severe presentation potentially. Next slide. And so, of course, if you probably have gleaned from looking at some of those images that the rash and its presentation can easily be confused with other sexually transmitted infections or other conditions. And it's really important to note that even just in our cases in New York City, but throughout this outbreak, we are certainly seeing multiple infections occurring at once. So, concurrent STIs also. So that's certainly, having a suspicion for monkeypox, means you should still certainly be working up and treating as needed for other STIs potentially. So, of course, we are seeing genital ulcers, and that can usually be confused with HSV, syphilis, less frequently LGB or granuloma inguinale. And, the diffuse full body rash can very easily be confused with syphilis, and that should certainly also be tested for and treated as needed. We have seen, some varicella cases during our testing that are presenting like monkeypox, so that's easily confusable too, and also less frequently disseminated herpes, molluscum contagiosum, and disseminated GC infections. With the proctitis, of course, especially when you can't see the lesions, that can be easily confused with and should be, kind of considered along with gonorrhea and chlamydia and HSV. Next slide. And so just going through some of the epidemiology that we are seeing to date internationally. We have 2 really helpful case series that have come out recently from the UK and Montreal, which have been kind of early hotbeds. And so in the UK, they published a study describing their initial 321st cases. These are occurring primarily among gay, bisexual, and other men who have sex with men. 99% of their cases were male, and the median age was 38 years old. And then they did a more detailed questionnaire with a subset of respondents just to get at some of the more likely risk factors for transmission. And among those who participated in the more detailed study, 44% had reported more than 10 sexual partners in the previous 3 months, and 44% had reported group sex during the incubation period. And this is really important when we're talking about, being stewards of resources and knowing where to target our interventions. And so Montreal, looking at their first 125 cases, again, 99% were male. I believe they may have had one household contact transmission that was not male. And then there were risk factors reported in this study, most likely include attendance at social or sexual venues or spaces, such as bathhouses, and then also reported sexual contact with more than 2 partners in the last, I believe it was 3 weeks. Next slide. And then this is just, a nice example of kind of a typical, atypical presentation. And this is a case report from Australia. And so in this case, we had a man in his 30s with well-controlled HIV who had developed a genital rash 5 days after unprotected sex with 4 male partners. So again, really the rash presented first, which was sort of atypical. And the initial symptoms were painless white pustules on the penis that evolved to become painful and pruritic. And then the fever and malaise, that sort of prodromal type symptoms began actually 3 days after the rash had started and then continued over the subsequent 5 days. And then the rash did disseminate to the trunk and more sparingly to the face and limbs, while the genital lesions crusted over. So those are all sort of atypical features in terms of the spread of distribution, and also the fact that they were seeing the rash in different phases of evolution. So as you can see, these are sort of very classic though looking lesions, really firm and deep-seated lesions that are sort of like little BBs under the skin. So that is still a pretty classic lesion. Next slide. And then this is just another deeper dive case series into more of the clinical presentations coming out of London. Their initial 54 cases they looked at. Again, all had identified as, of the 54 cases they were reporting on, all identified as MSM, men who have sex with men, with a median age, again, around 40 years of age, and 70% were white. 24% were living with HIV. In terms of presenting systemic symptoms, a majority, 67% had fatigue or lethargy. A little more than half had fever or lymphadenopathy. And then 18% actually had no prodromal symptoms. And 100% did report skin lesions. 90, almost all of them included anogenital lesions. 89% had multiple lesions, but 72% with lesions only affecting 1 or 2 anatomical sites. And this is really important. About 25% had concurrent STIs as well. So it really, again, highlights the need to make sure that you're testing and treating appropriately for other STIs. And 11% in this case series required hospitalizations, primarily due to localized cellulitis, superinfections requiring antibiotic treatment, and also for pain control, because these lesions can become extremely painful. Next slide. And this is just to make sure you guys are all still awake, a kind of picture of a good example of the anogenital lesions that may be presenting, a little differently and may be confused with other types of, other STI type infections. Next slide. And so my favorite topic is the treatment. So treatment is generally supportive. However, there is one particular medication that is available for treatment. This is Tecovirimat, or otherwise known as TPOXX, which is an antiviral medication. This is actually approved, FDA approved to treat smallpox. However, it is not FDA approved to treat monkeypox, which means it must be provided under a CDC-held Emergency Access Investigational New Drug, or IND protocol, which allows us to use it to treat monkeypox. This is an oral, this can be given either orally, twice a day for a 14-day course, or through IV. And so this can easily be given on an outpatient basis. This is only available through the Strategic National Stockpile, which is managed by the federal government. So request, to obtain this treatment does need to go through New York City Health Department. There is, some specific documentation because it's part of an IND. So each patient does need to have some certain documentation submitted to the federal government. And in consultation with us, we can help you get you through that process. In addition, we're also setting up some referral pathways that we will hopefully be able to facilitate, if you have a patient that is a confirmed case and you do not have the capacity to do the treatment offering yourself, we will be in consultation to help you make sure that the patient gets treatment. Next slide. And just we are now starting to stage doses here. So in New York City, we do have a cache of Tecovirimat. So if we do need to rapidly initiate a patient on treatment, that is definitely an option. And we will do our best to get patients that need it treatment as quickly as possible. So what patients should be considered for treatment? The easiest, most obvious one is patients with severe disease. And that includes hemorrhagic disease, confluent lesions, encephalitis, potential for sepsis. But also, in early stages of illness, we can also give it to patients that are at higher risk for severe disease, particularly people with severe immune compromising conditions, pediatric populations, particularly those under 8 years of age, have been described as higher risk. Those with history of an exfoliating skin disease, such as atopic dermatitis, and pregnant or breastfeeding women as well would all qualify for early treatment. Some complications, if they have more complicated disease, which we are working on a more kind of formal criteria for this. But, when we're seeing secondary bacterial skin infections, gastroenteritis with severe nausea, vomiting, bronchopneumonia, or other central nervous system, symptoms, we would certainly want to be proactive about treatment. And then aberrant infections, we call them, so places where there might be, just due to where the lesions are, there might be, kind of down the road complications such as conjunctivitis, eye involvement, really severe anogenital lesions that could place risk for, scarring or strictures. We would, want to be more proactive in treating those patients as well. Pain has been severe pain, and proctitis has been another thing that we're seeing more, and we have certainly treated patients for that as well. Next slide. And just, in terms of treatment, Tecovirimat, it has been, as FDA approved, it does have a very good safety profile. There are, it is a mild cytochrome P450 inducer, I believe. So, there are some considerations, but generally it's been safe and very well tolerated with a good safety profile. So vaccination, we currently have 2 licensed vaccines available. One is what we're exclusively using, which is JYNNEOS. And this is approved to prevent smallpox and monkeypox disease. So post-exposure prophylaxis in adults 18 years of age and older, pre-exposure prophylaxis in adults 18 years of age and older. And then there's ACAM 2000, which is kind of the older live replicating version that has to be given by the scarification with a bifurcated needle, a little more complicated process, a much more, has a risk for complications much more so than the JYNNEOS. So we have, preferred to use Jynneos, which is a live virus but non-replicating and has a very good safety profile. And then so the indications would be primarily post-exposure prophylaxis and pre-exposure prophylaxis. So for pre-exposure prophylaxis, we're really not recommending it for most clinicians and laboratories, although there is a recent, ACIP guidance that was published in the MMWR with more details if you're interested to see who would be considered eligible. But we are considering prep for laboratorians, specifically working with orthopox virus testing, including monkeypox. But in general, it's not. We'll talk a little bit more, but not necessarily indicated for most clinicians. Post-exposure prophylaxis is recommended for anyone with higher intermediate degree of exposure to monkeypox virus. If it's given within 4 days of exposure, it can prevent disease. If it's given after 4 days and between 5 and 14 days, then it likely will not prevent disease, but it's thought that if you do develop disease, it would reduce the severity of illness. Next slide. And so just talking about testing, we would consider testing for any patients, of course, with a clinically compatible rash who are within 21 days before symptom onset and meet any of the following criteria. So men who have close physical contact, that includes not just sexual contact, but also kissing, touching, just close contact with skin or body fluids with multiple or anonymous other men. And this is all based on our kind of epidemiology we've seen to date. Also, anyone with multiple anonymous sex partners, anyone who has contact with a person who is diagnosed with, of course, had a known exposure to confirmed or suspected monkeypox case. But also, since, of course, there is a risk for more broader community transmission, anybody that does have a, very characteristic monkeypox lesion, that deep-seated, well-circumscribed and with central umbilication, we would want to know about that to consider testing for. And among, recent infections, prodromal illness has not always preceded rash onset, and lymphadenopathy has not consistently been reported, and so neither is required for consideration for testing. We're really focused particularly on the rashes in this case. Next slide. And so how to test currently, and this is very quickly evolving, but currently testing is being performed through select public health labs, including the New York City Public Health Lab, and also New York State Wadsworth Lab is able to perform. This must be approved in advance by calling the provider access line and discussing the case with one of our medical team. However, really good news we heard yesterday is that the CDC is now sending test kits to 5 commercial diagnostic laboratories. So some of our bigger national reference labs that will be able to start receiving specimens. It hopefully will be within the next couple weeks, we are hoping. They said sometime in July they should be ready. So that is, something definitely pay attention to that space, and we'll send out announcements when that's an option, because hopefully that will really help speed up the initial evaluation. And then contact. So in order to arrange testing, call us at our provider access line as usual. And we have medical staff that can assist with the initial evaluation and determine testing is indicated and get you all the information instructions you need for how to collect, store, and transport the specimens, and arrange courier transport if needed. And so just for some context, there are, the US testing infrastructure for orthopox virus was an emergency response to smallpox. And so that's really kind of more what it was set up for, which is why it's a little cumbersome at this point. So when a test goes to our public health lab, it first has just a generic orthopox virus test. So just orthopox, yes or no. If it tests positive for that, then we then do a subsequent test that is basically a rule out variole or a rule out smallpox. So then that test positive, even though it's not a monkeypox specific test, if it is a non-variola orthopox test at our public health lab, then that is, in the context of this outbreak, considered positive for monkeypox. And then from there, the sample would get sent to CDC for confirmatory testing, but we can act on it as a positive case once it tests positive for orthopox at our public health lab. Next slide. And so I just encourage you, these slides will be posted. I encourage you, if you haven't looked at it yet, to take a look at this instructions that we have posted on our public health lab page, just to give you information. It's really important that, just for safety reasons for our staff and your staff, to package specimens correctly. It's very important that the specimens are labeled correctly on the containers. We really encourage all of you to, if you're not on e-order, to try and get set up on e-order, because that is how the ordering should happen, and that's how results are transmitted back. And then right now, swabs must be basically sent dry. And so we're working on implementing testing of swabs from viral transport media, but more to come on that soon, hopefully. Next slide. And then just infection control, some kind of key tips. So, of course, apply standard precautions for all patient care, including for patients with suspected monkeypox. If you see a funny rash, please don't touch it with, bare hands, wear gloves, just your basic precautions to avoid any unnecessary exposures. Avoid activities that could resuspend dried material from lesions, like we said, kind of like agitation or movement of, bedding, use bedding, things like that, use of portable fans, dry dusting, etc. Patients should be put in a single person isolation room, ideally with their own bathroom. It's important to note, just for patient management, a negative pressure room is not required, so no special air handling. It can just be a regular pressure room, but just make sure to keep the door closed if possible. However, healthcare workers who enter the room, in terms of PPE, so basically the PPE is the same as we would use for COVID: gown, gloves, eye protection, and a respirator, N95 or higher. And I know this is a little bit of a cognitive disconnect in terms of why aren't we using an airborne isolation room, but recommending respirators. The thought is, it's really the precautionary principle. So if there is a potential for, very close contact aerosol transmission, we want a no event policy. So that's why it's recommended to wear respirators. But in terms of the risk for, ventilation escape of aerosolized particles, that is not thought to be a risk. So that's sort of where that kind of disconnect happens and what the explanation is. And then standard cleaning and disinfection procedures should be used with EPA registered hospital grade disinfectant, and it should have the emerging viral pathogen claim on it. Next slide. And so how are we managing people with suspected or confirmed monkeypox? So any patient that has been had samples collected and are awaiting test results should stay isolated in a room or separate from other household members and pets. So this is kind of our home management once they go home. If the result is negative, they can then, of course, discontinue isolation. If the result is positive, they should continue isolating until, as we mentioned, all the lesions have resolved, the scabs have fallen off, and there's fresh layer of intact skin forming. When isolating at home, confirmed positive patients should stay home as much as possible and avoid, non-essential visitors in the home. Unfortunately, this is all instructions. We're very well familiar with this at this point. Do not engage be advised not to engage in physical sexual activity with others. If leaving the home for medical care or physical activity, please maintain a safe distance from others. They should be instructed to cover up all lesions, so no lesions are open, exposed, and they should be wearing a well-fitted surgical mask when out and about or in transit to medical appointments, etc. And we very much discourage, as much as possible, use of public transportation. Next slide. And so again, further information on managing. So taking measures to prevent others from having direct contact with lesions and contaminated materials. This is all just for you and advice for your patients. Again, cover the sores and wear face masks while in shared spaces. Do not share linens. Place linens, towels, and clothes in a separate laundry bag of the patient. They should have their own linens and they should keep that separate before it's cleaned. Avoid sharing dishes, utensils, towels, etc. Avoid direct contact with upholstered furniture that cannot be covered with sheets and then laundered for the fomite risk. And then we recommend, using separate bathrooms whenever possible, but if sharing, be very fastidious about cleaning and disinfecting bathroom surfaces after using if lesions are exposed, and definitely after using and if it's a shared bathroom. And again, they can use standard household cleaning disinfectants to clean and disinfect surfaces. And contaminated waste, particularly kind of medical waste that's been in contact with the lesions or exposed to secretions, should be put in a tight waterproof plastic bag, double bagged ideally if possible, and then discarded with the regular trash. And there are links here for nice detailed home isolation guidance that can be provided to patients by following that link. Next slide. And then how are we managing contacts? So when we do have a positive patient, we are at the DOH, our amazing team of medical epidemiologists and contact tracers are working with the patient to interview, identify contacts, and then facilitating symptom monitoring throughout the course of illness and helping to facilitate the administration of post-exposure prophylaxis to contacts as soon as possible when indicated. An assessment, for each of the contacts is made based on, to assess the risk of exposure for each potential contact. And then, as we said, anybody with what's considered a high or intermediate risk, any sexual risk or close physical contact is absolutely a high risk and would be considered for post-exposure prophylaxis. And so those with the intermediate or high risk would get daily symptom monitoring by text for 21 days from the date of last exposure. And then we are currently offering post-exposure prophylaxis through our designated vaccine site, which we will arrange directly with the patients or contacts. With low exposure risks, we just recommend daily self-monitoring by text for 21 days from the date of the last exposure. Next slide. And then healthcare workers and monkeypox, just want to reiterate PrEP at this point is not routinely recommended for healthcare workers. Really, and this is based on the fact that there is very, very little evidence of risk of transmission from what we've seen to date, and we'll talk through that. We're really seeing transmission through prolonged direct contact, mainly through sexual and intimate encounters, and that's really driving this current global outbreak. Among the cases identified in US to date and in this global outbreak to date, none have been healthcare workers exposed in a healthcare setting. And, really, as long as you're using appropriate PPE and standard precautions, the risk should be considered extremely low. Next slide. So healthcare workers and monkeypox, just some kind of data on why this is considered a lower risk. So with this current outbreak in the case studies that we saw in the UK and so far in the US, in the UK, there were 384 healthcare workers identified with known exposures. 245 of those were medium high risk. Not all of them received post-exposure prophylaxis, and none developed signs or symptoms of monkeypox. And then just historically, as you can see, several outbreaks that have described, multiple healthcare exposures, many which were higher risk, and none have developed infections except for the one case that I mentioned in the UK, where one healthcare worker developed monkeypox after, basically a bedding change when they were not wearing respiratory protection. Next slide. And so just what are we doing, in addition to everything that we've already mentioned, to summarize? So, doing our best to provide timely guidance to our provider community and assisting with the screening and diagnostics, arranging for testing, case investigation and contact tracing, which has been a really intensive operation so far. These are very labor intensive to manage each of these cases. We've been reaching out to identify close contact to provide, information on caring for themselves, what to look for, monitoring for symptoms, and offering the Jynneos vaccine as post-exposure prophylaxis. We are facilitating access to Tecovirimat and setting up, systems that will facilitate easier, quicker access. And treating specimens, testing specimens at our public health lab, providing information. In particular, there is, particularly it's Pride. We have a lot of amazing community partners, community-based organizations that work with at-risk communities that we're working with to get information and do outreach to our at-risk communities and those working with these partners working with these communities. We are doing some targeted media campaigns, particularly advertisements on digital platforms, and then just continuing to really do our best to focus on dissemination of really facts-based and, most importantly, non-stigmatizing messaging to New Yorkers about their risk and what to look for, and really focus on empowering messaging rather than stigmatizing messaging. Next slide. And kind of our new exciting development, this was announced and kicked off yesterday. So we are the first jurisdiction in the country to offer what we're calling expanded post-exposure prophylaxis for people who, are at higher risk to have potentially been exposed to monkeypox already, due to their, recent risk factors. So eligibility criteria would be gay, bisexual, and other men who have sex with men, cisgender or transgender, ages 18 and older, who have had multiple anonymous sex partners in the last 14 days. Currently, we are offering it out of our Chelsea Sexual Health Clinic, although we are hoping, once supplies allow, to expand to at least one or two other sites. And those eligible, we do have an online now scheduling app. Of course, this is a limited resource in terms of capacity for each day. So, if you have patients that are trying to get appointments, please, just have patience, and keep trying to make an appointment if they can't get one right away. There have been some slots for walk-ins, but we really definitely prefer that you make an appointment. And the clinic is going to be open Mondays, Tuesdays, Thursdays, Fridays, and Sundays from 11 a.m. to 7 p.m. And next slide. And so what do we need from you, particularly our provider community, our wonderful partners, the most important people that we work with on this? There have been anecdotal reports of patients being refused care, or basically have come in or called providers and then been referred elsewhere, which can lead to a lot of frustration for the patient, and difficulties in accessing care, delays in diagnosis, treatment, and prophylaxis, and just really adds to the feeling of stigma and isolation. So please, please do not turn away patients. Evaluate and pursue testing of patients suspected of monkeypox. Call the provider access line. We will do everything we can to help you and talk you through it, and try and make it as painless as possible. We know there's a lot of steps to jump through, and we're working as hard as we can to eliminate barriers as much as possible. And then please, when speaking about monkeypox with patients and other colleagues, emphasize really anyone can get infected. We are seeing, in this current outbreak, men who have sex as men have been at higher risk because this just happens to be the social networks that it was introduced into first. But there is, certainly the potential for, others to get infected based on, exposure risk. So please, of course, avoid making judgments and stigmatizing behavior, be compassionate, getting turned away from care, and it can be a really scary experience to think that you have this, so as much as we can be compassionate, empathetic, and really try and help our patients through this really difficult time, it's better for everybody. And so, together we can all provide, really ensure and do our best to ensure that people are receiving affirming care, improving individual health, and reducing transmission together. And I think that's the last slide. And then we now have some great resources available. We have a general public-facing monkeypox page. We also have some information very specific to our men who have sex with men community, with a lot of great messaging and materials, palm cards, et cetera, for patient messaging and education. And then now we have our provider page up and running with information to help you either continue to see patients or getting ready to evaluate patients, because we are expecting, Pride is on Sunday, I believe, but there have been activities going on all month. So, we're certainly expecting that the trajectory of this is, only going to increase in transmission cases. So, we just ask that you all be ready to, be partners in caring for these patients. Next slide. All right, thank you so much. And we have our amazing subject matter experts on the line with me to answer questions.
Hi there, everyone. This is Dr. Ray. I've picked out some questions from the chat that have come up. And I'll kind of throw these out there because we have a lot of different experts who know a lot of different stuff on this call. I think one that we are seeing a lot, thank you, Dr. Foote, for your explanation of the epidemiology for healthcare workers and precautions for healthcare workers. We've had a few questions about whether, the access for healthcare workers to the vaccine. I know that this is evolving, but if someone could just comment on that.
Sure. Hi, this is Jennifer Rosen. At this point, because the vaccine supply is so limited for the country, and because healthcare transmission to date has been incredibly rare, per CDC at this time, most clinicians in the United States are not advised to receive orthopox virus pre-exposure prophylaxis with vaccination, and clinicians should continue to use recommended infection control practices.
And then I think, we are getting a ton of questions similar to that about the vaccine availability for patients as well. And I believe, Dr. Rosen, that your answer should be a good response to that. This is evolving. And so, we will, I'm sure, have more information and more updated information on access in the next week.
And if I can just add one more comment or a correction.
Absolutely.
For originally the clinic that's operating for expanded post-exposure prophylaxis, we were accepting walk-ins and appointments, but because the vaccine supply is so limited, all people now need to make an appointment. There are no longer walk-ins accepted.
Thank you, Dr. Rosen. Sorry for that confusion.
Oh, sure, it just changed.
And Dr. Rosen, last I heard the appointments were already booked till Monday. Is there an update on that?
No, people will need to just check back. We are hoping to get an additional supply from CDC shortly, and we'll open up more appointments as we get them. But just for reference, because I also saw several questions about what is the supply, and as of recently, the vaccine, which is held by the Strategic National Stockpile, they only had enough doses to vaccinate 36,000 people. So we have gotten some of that supply, but obviously many different jurisdictions are now requesting vaccine. They are anticipating many more doses over the next few weeks and over the course of the year.
Great, thank you, Dr. Rosen. I think that was our biggest question. We got a fun one that I feel like maybe Dr. Foote will be able to answer. But if you've got if you've had the smallpox vaccine, are you safe from monkeypox?
Actually, Dr. Rosen would probably.
Sure, yeah, it depends on when you were vaccinated, but for people who have been recommended to get vaccination, for example, because of occupational exposure, a booster dose has been recommended, every so many years for people at ongoing risk. So someone who maybe had smallpox vaccine as a child, a long time ago, if they had a known exposure to a case and the health department has confirmed that they are eligible for post-exposure prophylaxis based on having high-risk exposure, then they would still be eligible for getting vaccination as post-exposure prophylaxis.
Thank you. And so we've gotten a lot of questions also about the about testing capacity and the potential expansion of testing capacity. Will tests eventually be available commercially, and what will those tests be? Will they be monkeypox or orthopox? So that's a whole bunch of them, but I think they're basically the same question. So if someone wants to take that.
Are any of our colleagues from the lab on?
I don't believe so, but maybe Dr. Wong has a little bit of information on this. I don't want to put you on the spot.
I apologize. Can you repeat the question again?
Sure. Just about, we just had a bunch of questions about testing capacity, whether this will be available, whether orthopox tests or monkeypox tests will be available, and will they be available commercially?
Yeah, I think Dr. Foote mentioned that the CDC is sort of trying to develop some more commercial lab testing capacity. Right now, our capacity with our lab is around 10 per day, which I know is very low. And I know multiple avenues are being explored in terms of being able to test more patients on a daily basis until a more commercial lab is available. I think that's all I know at this point. If other folks know more, then feel free to chime in.
Hi, this is Dr. Randall Fowler from the Public Health Lab. I can comment further on this. So just to provide some clarity, 10 patients is what we are testing per day. So the current guidance from CDC is to test 2 samples per patient, and these samples and patients are being triaged by the Department of Health to identify whether or not testing is warranted. Regarding capacity, there are multiple factors that we are exploring to increase our capacity, and we're hoping to have some solutions in the next couple weeks. We are restricted based on some reagents and some guidance from CDC, but those are we're working on that right now. And then regarding the commercial labs, CDC is working very closely with, I believe, 5 major commercial labs to bring on the orthopox testing. And so that is something that CDC is working directly with those laboratories on. There hasn't been any guidance or communication regarding regarding logistics on sample submission or any details regarding commercial testing as of yet. And then I guess the one last thing I'll add is right now the conversations are just surrounding testing for orthopox virus and not testing specifically for monkeypox. So currently, CDC is the only laboratory in the United States that is currently able to test specifically for monkeypox.
Thanks, Dr. Fowler. And I think we have a couple of different questions here about getting in touch with the health department. We are staffed 24 hours a day to answer your calls, answer your monkeypox calls. You can always call the provider access line, and then I don't remember the number off the top of my head, but maybe one of my colleagues can try to put it in the chat. I think that we, just a reminder also, we had a question, we have a question about patients without insurance. I mean, we don't know what commercial labs will do, but for patients without insurance who need follow-up care, you can, we always recommend that they call 311 and be connected to our public hospital system to be connected with insurance. All right, and I think that there were also some questions about, there was an interesting question about subclinical transmission, and also, I think it might be useful to address inoculation, so an exposure to the virus where a patient would not become ill but would develop immunity, and what our latest updates are on that.
Well, I can say we are certainly seeing, a very big spectrum of illness, and as we said, some, may not even be presenting with, obvious lesions initially. We don't know to what degree that kind of subclinical patients, may be able to transmit, but there are actually, national serosurveys being planned just to get a better sense of, the potential for asymptomatic cases, thus asymptomatic transmission. So hopefully we'll be learning more soon about all that.
Great. And I think that this immunity conversation is going to be very interesting, and will also, like almost all of the questions that were asked today, our understanding will evolve over the coming weeks. I think that we are at 2 p.m. right now. I believe that the presentation and the slides will be available shortly after the end of this talk on our provider website. Thank you, everybody. Do we have any other housekeeping for around these webinars?
Thank you, Dr. Ray. No, if another webinar is scheduled, we will distribute that information to all those who have attended today. In addition to posting the slides and recording on the website, which is linked in the chat, we will also email that information to all attendees. It should be posted by tomorrow, and then we will email you that information by Monday. So we thank you again for joining us.
All right, thanks, everyone. I'm sure we will be